Everyone, we are starting insulin. This is the most important topic, and most of the general practitioners, physicians are very well. They are doubtfully looking this topic whether to start initiate insulin, how to titrate insulin like that, intensification of insulin. So let's discuss it here. What we'll discuss is that here we'll discuss about different types of insulin, how it is used, how it is initiated, how it is intensified like that. So first we should understand that we have two type of insulin. As a dictum, we have a two type of insulin, that is a conventional insulin and analog insulin. We all know that conventional and analog insulin, these are the basic two type of insulin. What are conventional insulins? Conventional insulin are short acting and intermediate acting like that. That is, first one is short acting conventional insulin, that is the regular insulin. Short acting conventional insulin, that is a regular insulin. Next comes the intermediate insulin, that is NPH, that is also short acting regular insulin. Short acting, that is also intermediate acting conventional insulin. So the points to be noted here is regular insulin. This is a regular insulin is conventional insulin. It is known by the name insulin R, insulin R, vosulin R. Okay. When coming about NPH, that is intermediate acting insulin, it is also a conventional long acting insulin. Okay. Then comes the analogs. Analogs means we discuss about the rapid acting insulin. These are rapid acting insulin. These are rapid acting insulin. Okay. So rapid acting means its action lasts for about 6 to 8 hours. That is Lispro, Aspart, and Glulisine. These are the rapid acting insulins. You should understand that the Aspart is now, we have another form of Aspart which is faster acting, that is called FIASP. Okay, this is the FIASP insulin, 100 units per ml, which is a rapid acting insulin. Next, the Aspart is now in market as a Novorapid. Glulisine is Apidra, the trade name. Fiasp insulin can be given even after food. 20 minutes after food itself, we can give this Fiasp. Why? Usually we take insulin before food, 20 minutes before food or 15 minutes before food. But in Fiasp, which is a highly rapid acting insulin, that is ultra short acting insulin, we can use it even after food. Sometimes in type 1 diabetes, young students or babies, they skip food. They take food late. In that also we can use this such type of insulin. Okay, Fiasp insulin. Next comes the long acting insulin, that is the Detimer. Its duration of action is 12 to 6 hours, and so it's better to give 2 times a day. Just see the slide. This is a Detimer long acting. It's about 12 to 16 hours action is there. Okay, 12 to 16 hours of action. So better we should give 2 times a day. So Glargine is also long acting. Glargine, it's known by the name Landes Beselog. It works between 16 to 22 hours. 16 to 22 hours. So Glargine works 16 to 22 hours. So the Glargine has been now in two forms, U100 and U300. In U100 it is 100 units per ml. In U300 it is 300 units per ml. That is Glargine. Next comes the Degludac. Degludac is known by the name Tresiba. The Tresiba is the longest acting. It works. It works around works 24 hours. Sometimes it may work more than that. That studies have proven that it may act for 48 to 72 hours. Okay, the Tresiba can act for 48 to 72 hours. The Tresiba and U300 comes by the name of Tagio. Very important, Tagio. Okay, so let's assume a businessman. I'm a businessman. I am not having enough lunch break. Just only 20 minutes of lunch break. Oh God, 20 minutes of lunch break. What can you do with that? In that patient, it's not possible to take insulin before 20 minutes of lunch and take lunch after that. In such case, we can use FIAP. What is FIAP? It is Aspart, which is the fastest acting Aspart. We have just shown that FIASP. Okay. Next is some important points to remember, guys. Okay, long-acting insulin, we told it as a Detimer and Glargine. Glargine can be 12 to 16 hours. So Glargine, see, 16 to 22 hours, I'm sorry, 16 to 20 hours. The Glargine should be injected at the same time every day. Okay, same time. If you're injecting in the morning, it should be injected at the same time. If you're injecting at the evening 9 p.m., it should be injected at the same time next day also. But for Dagludac, which is the longest acting insulin, Dagludac, the longest acting insulin Tresiba, there's a flexibility of 6 hours. Okay, so you can inject in afternoon or you can inject in night. It won't matter. You can use it anytime. The Tagio, which is the Glargine plus the Tresiba is plus U300. That is the Tagio. The Tagio is a U300 and the Tresiba is a Degludag. There is a flexibility of 3 hours, 6 2 p.m. to 9 p.m. You can take anytime. Now discuss about the vials and strength. Two vial combinations, 40 international units per ml and 100 international units per ml. These are the two vial combinations. See, this is a 40 international units per ml. One vial contain 10 ml, so it is for 100 units in one vial. Okay, so in such insulin vial, you should only use a insulin syringe with a red cap, that is a 40 units insulin syringe. 40 units insulin syringe. Don't take 100 units. Okay, in another case, this is the 100 units vial. That is per ml 100 units, 10 ml, that is there is 1000 units, 1000 units in this 10 ml. Here use only 100 units syringe. Okay, 100 units syringe. Don't mismatch. If you take mismatch, if you cross and they take, if you take a 100 unit syringe and you take a 40 units vial, what 1 ml only has 40 units, but you're thinking that it's 100 units, but so low dose. But if you're taking a 40 unit syringe and taking a 100 vial, your insulin vial, which 1 ml is, you think that it is 40, no, but it is 100 units. So it is 2.5 times larger or higher quantities you are insulin injecting. It can go for hypoglycemia. So 40 unit syringe, 1 ml is 40 units. 100 units syringe, 1 ml is 100 units. So if you mismatch and use 40 ml syringe in 100 units insulin bottle, what do you do? What will happen? You are injecting 2.5 times higher dose. Okay. So if patient had injected 10 unit using the 40 unit syringe to a 100 unit vial, then you are actually injecting 25 units, which is more, and you should be very much cautious about that. Otherwise, the patient will go for hypoglycemia. Next, a question arises. Is 100 international units per ml better than 40 international units per ml? You just consider one thing, a cotton of 1 kg and you consider a gold of 1 kg. Okay, gold of 1 kg. Gold of 1 kg is very small. The cotton of 1 kg is very big. The volume is big, but both are 1 kg. Similarly, so whether you take a 40 international units or 100 international units, 1 unit is always 1 unit. Remember that. Okay. Next, which are the sites you inject? You just most of the time people inject themselves, but you keep in mind that the injection procedures, you pinch the skin, then inject the insulin like that. You should inject. Okay, you place it like a pen. That's okay. It's like a pen. These are the sites of injection insulin. Just this is not very important. You just remember it. To communicate to the patient that what the dose you want, what all dose that you what you take, how much dose you should take per day or per BD, OD or TDS, you should know, and which type of insulin. That's very important. You should use a short-acting insulin, or you should long-acting insulin, or a basal bolus, or whatever it may be. You talk to the patient these important features. Then whether it is feasible, conveniently pen or syringe, what it is. A pen is very much costly than syringe, but it is convenient to use pen because it is self-administered. So ask the patient whether to use this or that. Okay. Then you come the regime. Premixed insulins are we are not at all encouraging premix, but we can use. Later we'll study it. Then injected by self, injection site, timing, regular or not, whether brought from standard medical shop, expiry date, storage, everything. Cold chain is very important. Okay, cold chain storage. We can use in a local setup. You can use an earthen pot, fill it with water and sand, water and sand. Then use another pot. We can immerse. We can use pour some water here, water, and put the insulin in a cover and dip it here. So earthen pot, sand and water here. Then another pot, water, put the insulin in cover, dip it here. Such way we can use in local setup. Okay, which and when you use 30-70 or 50-50, and where to use, when to use, what could be used. So if you're taking a low carbohydrate meal, better you go for 30-70, because the 30-70, the 30 is a short acting, and this 70 is intermediate or long acting, intermediate or long acting, intermediate or long acting. So if it is a low carb meal, you require only very short acting insulin is very less is required. So you go for 30-70. If you're eating a bulk breakfast or a high carb meal, then the fast acting insulin, that is instead of 30, you use 50-50. The fast acting insulin should be higher. So it's dependent on the food pattern of the patient. Okay. Let me tell you that there are questions arising that whether early initiation of insulin preserve beta cells. These are the questions arising these days. You know that the beta cells are producing insulin. Whether to give rest to the beta cell, resting the beta cells. Some data suggests that within 3 months of detecting diabetes, if you start insulin, then we can preserve the beta cells. Mostly in 80 to 90% of beta cells we can preserve. These are studies. So some data also suggests that if you start as a vildagliptin and metformin, these are actually insulin sensitizers. Vildagliptin and metformin at the earliest, it will help in preservation of beta cells. Very important. Okay. These are data suggesting, these are studies. So delay in complication. What is delay in complication? You can delay the complications like microvascular as well as macrovascular complications like strict glycemic control, legacy effect, metabolic memory. These are UK trials. These are what is legacy effect. Suppose the sugar are controlled in initial years of diabetes. Suppose for first 10 years, the sugar is very well controlled. In first 10 years, the sugar is very well controlled. The remaining 10 years of life, the sugar is not under control. So study have shown that the patient having good glycemic control in the initial years of diabetic has shown lesser complication compared to those having poor control in compared to poor control in initial 10 years. So first 10 years is very important. You give strict control in the first 10 years. Okay. And what is insulin distress? Well, you're talking about insulin distress. When you initiate insulin, the distress of patient, there is a distress of patient. They will be not mentally conveniently satisfied to use the insulin. So you listen to the patient, support to the patient, and the teamwork, empathy, neutral, not judgmental communication you should take. So what are the common mistakes that we encounter while we're initiation or seeing whether the insulin therapy? Whenever we see high value sugar, we usually label the patient as a type 2 diabetes. We just forget everything and we label him as a type 2 diabetic patient. Is it that right or not? You think and say, no, man. There can be many reasons. It can be steroid-induced diabetes mellitus. It can be type 1 diabetes mellitus. It can be pancreatic diabetics. It can be fibrocalculous pancreatic diabetes. It can be CCPD, acromegaly, Cushing's. So evaluate it clearly. Okay. So now comes the basics of initiation of insulin. This is the topic that we are starting with. This is an important topic. Come to the important guidelines. Okay. So what we'll do is we have three types or mixing regimes. We are three types. First one is basal insulin. Okay, basal insulin. Second one is premix insulin. And third one is basal bolus regime. All these three has a different advantages and disadvantages. To be frank, I say basal bolus insulin is the best method to follow for the good glycemic control. That will depend upon the patients who are taking this insulin. Basal insulin means we use a long-acting insulin. Either you use at night or at day. If it is glargine, use at night. If it is degludec, you have flexibility period. That is a Trasiba. Basal insulin you should do only once. You should take only once, simple, and it is less chance of hypoglycemia. But it's premixed insulin, like this insulin 30-70, 50-50. They are very easy to use, but it's very difficult to adjust because if you see that if the sugar, the fasting sugar is 250, or if the postprandial sugar is 350, if you increase the dose of 30-70 insulin or 50-50 insulin, many problems are there because the 50-50 insulin, the short-acting insulin is also increasing along with the long-acting. So it's very difficult to control in premixed insulin. The basal bolus, this is a very good method of controlling insulin. Basically, insulin production is better controlled. There's a chance of hypoglycemia, but it is it's 4 to 4. If you take that disadvantage, is 4 to 5 times. There is only the disadvantage we encounter here. So you take NDA bolus, basal bolus. The NDA basal bolus means what is that? First, you check the basal insulin. This is the basal. It is not bolus, it is basal only. So when you're eating the breakfast, there is a surge of glucose, then it comes down, then lunch, a surge of glucose, then it comes, then dinner, the surge of glucose. If you're taking a basal insulin like a glargine or a detimar, the insulin action will be constantly around the clock. Okay, that's a basal form. If you're taking a prandial insulin, that is a bolus regime. This is a bolus regime. For each time or breakfast, you take an insulin before breakfast. That is a short-acting insulin or a rapid-acting insulin. Before lunch, you take a break, insulin. Before dinner, you take insulin. So basal bolus, that is what? This is the basal bolus. This red line, you show the basal insulin, and this violet show the bolus insulin. That is, we take a glargine or a long acting, it will be continuously acting over the day. From each breakfast or each lunch before each dinner, we use a short acting insulin. In type 1 diabetes, we inject 4 times a day. That is better. Okay. The glargine, the long acting insulin, glargine. See, the glargine is acting a long acting, that is around 16 hours. The normal insulin production is like this. Our physiological insulin production during lunch, breakfast, there is a surge. This is normal insulin productions. The glargine, when you're giving at night or at morning, the action goes like this, and at the evening time, it weans. Okay, this is a long-acting glargine insulin. And there is the NPH, that is a neutral potamine, that is an intermediate acting. Its action is around less than 10 hours. So you take that NPH at 10 p.m. Mostly NPH are taken 10 p.m. You take 10 p.m. insulin, the insulin rises like this, and the action will be higher at the midnight. Then it falls in the breakfast, lunch time. So if you're taking NPH alone, the daytime sugar will not be under good control. Okay, let me check it later. The premix insulin that we told 30, 70, 50, 50, like the 30, 70, 50, 50 insulin, that premix insulins. We give a regular insulin before dinner. That is this one, this pink one. No, that violet one. The NPH action will go so like this. So we are focusing at the dinner control. Premix is not good a choice. Why? Your premix is given just before dinner. There is NPH plus regular insulin. That's not a good choice. It will not get a good control. The premix insulin given twice a day. Sometimes actually these are followed. These are followed nowadays by most of general practitioners. But actually, it's an see. You give a 30/70 at morning, which is a regular insulin, or you give a regular insulin along a separate injection at morning before breakfast, and you give a similar regular insulin before dinner, and you have NPH also. But what here we see is the noontime insulin production. Then the noontime there is no control. So what here can use, we can add a regular insulin at the noon also. That will be a good idea. Otherwise, the noontime insulin will not be easier because here we add a regular insulin at the breakfast along with an NPH. So it go like this. The NPH value will go up until the evening. Next, we'll go at the night, the regular and the NPH. So in between, some surge of sugar will be there in between. So better use a regular insulin. So my opinion is, if you prick 3 times a day, then why can't you prick 4 times, just one more time? So you can use basal bolus regime. Today breakfast is more, then I can increase my basal bolus. But that is not possible with premixed. Why? Because if the breakfast is more, if you take more insulin, it will actually go for hypo, because the rapid acting insulin is also increasing. See, it will go for hypo, and the rapid acting as well as the long acting insulin is increasing, or NPH is increasing. Let's discuss the guidelines for insulin initiation. In guidelines, we use several guidelines. Most of the guidelines, the IDF, RSSDI, AACE, AD, American Diabetic Association, most of the guidelines says that the basal insulins are used. Only the RSSDI guideline says that both the basal and premix can be used. But that is for Indian setup. The patients of Indian use carbohydrate more. That is 80%, around 80%. That's why RSSDI say you can use premix. But the guidelines say better to use the basal bolus regime, basal insulin regime. Okay. So first here, in the guidelines say the initial therapy is always metformin. Okay, always metformin initial therapy. Then you go for comprehensive lifestyle modifications like weight management and physical activity. You check that whether it is a high risk patients with a CKD, heart failure, or ASCVD. In such case, you consider a baseline A1C, HbA1c level, individualized A1C target, or metformin use. If you see a patient with a high risk, that is ASCVD, indicators of high risk, in such cases, established ASCVD indicated high risk ASCVD more than 55 years of age, coronary artery problems, stenosis, LVH. In such case, you can think of starting a GLP-1 analog or SGLT2 inhibitors, with both having proven cardiovascular benefits, like dapagliflozins, and that exenet, like a good client like that. If A1C is above target, that is, if there's a first you add metformin, then there is a risk you add this GLP-1 analogs and SGLT2 inhibitors. If at all the A1C is above target, you intensify is required, or patient is unable to tolerate GLP-1 and SGLT2, choose agents demonstrating cardiovascular benefit or safety. For patients on GLP-1 analogs, consider adding SGLT2 inhibitor with proven CVD benefits, cardiovascular benefits, or DPP inhibitor. If not, like that you can add. But what I mean here is, if all those things fail, you can go for a basal bolus insulin. Sulfur and ureas are last things because they are insulin secretagogues. So the depletion of insulin cells, beta cells, is very high with sulfur and ureas. So the basal insulin is the next therapy to be initiated. That's given here. The guidelines say you are starting basal insulin here, and the guideline also says that here, check, the consider basal insulin with a low risk of hypoglycemia. See, consider a basal insulin with a low risk of hypoglycemia. So that is second generation insulins, like low risk of hypoglycemia, second generation basal insulin like degludec, that is Tresiba, then U300, like that. We use second generations. For patients who are having, he said ASCVD, in which high risk patients who are obese, who are hypertensive, who is having dyslipidemia, urine microalbumin positive, you start with the GLP-1 analogs or SGLT2 inhibitors. So we should here notice that we should start an injectable GLP-1 analog before you start an injectable basal insulin. Okay, injectable therapy. Those who have heart failure, better we should use SGLT inhibitors even if non-diabetic. But heart failure SGLT inhibitors are indicated. Okay, which patient do not need district type semi-control? These are autonomic neuropathy patients because the sympathetic functions are masked. Here also he say heart failure. Heart failure. Here also we think heart failure with ejection fraction low. Better to go for SGLT2 inhibitors with proven benefits. Also in CKD, we use preferably SGLT2 inhibitors because it is renoprotective also. Okay. For patient with type 2 diabetes and CKD with the EGFR less than 60, there's increased risk of cardiovascular event, you can go for these SGLT2 inhibitors with the proven benefits. These are the important points to be remembered. Dealing about gestational diabetes, the fasting, the target sugar should be 60 to 90. 1 hour prostaglandin is less than 140. 2 hour prostaglandin is less than 120. One important thing you should remember that is do not use a premixed insulin TDS. For that, better you use a 30/70 at morning and at night, and a regular insulin at noon. If patient is obese, we start at a higher dose. If patient is thin, we start a lower dose. It's published in papers. So the basal initiation, there's a B Smart technical, B Smart regime. It is a published paper of the American Diabetic Association. The B Smart means basal early strategies to maximize HbA1c reduction with oral therapy. Like these are Indian guidelines says that initiation of insulin, that is a basal insulin, it can be NPH, glargine 100, detimer, degludec, or glargine 300. That is a 2GO. You start with 10 units per day, or either you can go for 0.1 to 0.1 units per kg per day. So suppose it's a patient of a 50 kg, it will be 5 to 10 units per day. So that is usually taken at bedtime. That is long acting. Suppose the patient is having a weight of 112 kilogram. In such case, the patient is obese. We don't take this rule as 0.1 to 0.2 practically. We just sometimes we use a 0.2 or 0.3 we can use per kg per day. We may start with 20 units because since the patient is obese, that's why. The because what for monitoring, what we use a fasting glucose. Okay, fasting glucose. You see that for if you since you have initiated insulin, how do you adjust those? For that, you need fasting glucose level, fasting sugars level. Fasting sugar targets are different for different populations. For example, if a patient with severe complications, we don't cannot go for strict control, so relaxes the control. But if a young patient, he has so many years to live, we go for a tight control because you have to prevent the complication as much as possible. So take a dicting that the fasting sugar target should be 180 to 130 milligram per deciliter, should not go beyond 140. Okay. Titration, first method is till fasting blood sugar reaches 140, every third day you increase 2 units of basal insulin. Okay. So take an average of 3 days. Day 1 is 100, day 2 is 120, day is 200. You don't increase the basal insulin blindly because consider his diet also. Whether yesterday night if he has taken a biryani or some big diet, the fasting sugar may increase. In the recent 3 days sugar, you take the lowest 100 units, 100 fasting sugar, or you take the average. If it is 100, it's normal. You continue with the same dose because it will be because that one day she has a cheat day, he had a heavy dinner. Otherwise, if you are continuously consecutive days, you're having insulin 150, 170 like that, you increase by 2 units every three day. Okay, you can either consider the lowest of the three or you can take the average. So that is titration, that is increasing the dose. Titrating insulin dose based on average of 3 most recent values. So reduce dose in case of hypoglycemia. Next comes the intensification. Intensification means adding a bolus insulin, or other insulin lowering agents if postprandial glucose is elevated. Monitor HbA1c at every 3 months. Comes the intensification. Okay, intensification. What do you mean by intensification? You means adding the bolus. So what does it mean? It means that you have given insulin per day, that is zero point 0.1 to zero point 0.2, like that you add, you reached the maximum of 0 units per day per kg, but still you are not getting the control. That is fasting and PPBs. Then you have to intensify. You can add a single bolus one day, one time, or two time, double bolus, or triple, three bolus. That is basal bolus regime. To be frank, this is the best regime which is very useful in clinical setup. A question is, do we need insulin in patient who has HbA1c more than 10? To be frank, an American Diabetic Association says that if HbA1c is more than 10, consider insulin. Another American Academy of Clinical Endocrinologists says that if patient is already on OHA and HbA1c is more than 10.5, then consider insulin. If not on OHA, then HbA1c more than 9, you consider insulin. Okay. If you OHA, when you are using multiple OHA, how to change to insulin? So if you are giving basal bolus insulin regime, then secretagogue drugs OHA are removed. That is OHA like glimepiride, glycoside, glipizide. Because in such patient already the beta cells are exhausted. That is secondary OHA failure. Uh, so if you are converting OHA to insulin, uh, you should skip secretagogues, but you start sensitizers, insulin sensitizers drugs like biguanides, metformin, gluphosins, SGLT2 inhibitors, incretins analogs like that, because it sensitizes the insulin for its action rather than depleting the beta cells, that is secretagogues. Okay. Why do you titrate basal insulin based on FBS? That is concept is FFF, that is first fix fasting. Higher HbA1c, you go beyond 10%, it is actually fasting blood sugar which is responsible for that HbA1c. Whereas in lower HbA1c, less than 7, here the fasting as well as the PPBH contributes for HbA1c. So fasting blood sugars are to be adjusted first. It's a FFF regime. See here. Here, the fasting sugar is HbA1c is 10 more than 10% here. The fasting sugar is responsible for that. When HbA1c is 6 to 9%, both fasting and both two are responsible. But in case of more than 10%, the fasting is responsible. These are studies conducted. See, this violet is fasting sugar, and that contributes to more than 10% of HbA1c. So these are studies conducted and proven. So first fixed fasting. That's very important. So for titration of insulin, you check fasting level, recommended dose are distant. We told that a fasting FFF is responsible for intensification of insulin. So if the fasting sugar is less than 80, once or twice a week, you reduce the dose by 2 units once or twice 2 weeks, twice a week. So if it is the fasting sugar is 80 to 130, you don't need any modifications. If fasting sugar is 131 to 160, you increase dose by 2 units. If it is 161 to 180, you increase dose by 4 units. If it is more than 180, you can increase dose by 8 units. Okay, so basal. Which basal insulin do you prefer? Do you prefer NPH, Detrimer, Glargine, U100 or U300 Degludec? NPH is not at all used because its duration is actually only 12 hours. For basal insulin, we need more than 16 to 24 hours. So Detrimer is preferred in pregnancy because we have data suggesting that it's very good in pregnancy. Glargine U100, that's called Lantus and basal, it's taken usually on the night. Glargine U300, that is Tugio, along with the Degludec, that is Tresiba, better in IP patients who are feeding. Okay. The NPO patient avoid subcutaneous insulin. Use infusion Degludec can be given at varying time of day. Don't use a subcutaneous because the patient can go for hypoglycemia. What time the day you give basal insulin? Okay, that's an important question. That depends on the insulin, the type of insulin you take. Okay, if you take Tresiba, that is a Degludec, the longest acting, then you can give it any time because there is a flexible time interval. Actually, there is nothing to do with timing of food if you're taking the Degludec. See, this is a round the clock chart. This is the 8 a.m. morning, noon, night, 12 o'clock. This is the next day. From here, it is the next day. So when you take a basal insulin at 8 a.m., the insulin level goes on higher and peaking at the night, I think at the mid-noon, and basal insulin effect is weaning. So less nocturnal effects, less of nocturnal hypoglycemia. The nocturnal hypoglycemia is very less during the midnight. This comes the midnight. See, this is the midnight. So the nocturnal hypoglycemia is very less. But some of us prefer basal insulin at night because by you can adjust the fasting blood sugar. That's why. So if you're taking a longer insulin like a Tresiba, Degludec, either you can use at any time. That doesn't matter. Intensifications. AACE guidelines use intensifications. It's the algorithm by AACE. See, in patients who is having an HbA1c more than 8 and who are already on OHA, you take the total daily dose as 0.2 to zero point 0.3 units per kg. Okay, total daily dose. So if it is 60 kg, it can be 12 to 18 units of basal insulin per day. So insulin titration every 2 to 3 days to reach glycemic control. Here we have already discussed that the units that we have to increase. For adjustable regime, we can take that if it is more than 180, add 20 percentage of total dose. 140 to 180, 10 percentage, 110 to 29, and 1 unit. Okay. So if you add a basal regime and you are not controlling a glycemic control at the goal of 80 to 130 or 140, you add a GLP-1 analogs or a SGLT2 inhibitors. Better not go for secretagogues. Use insulin sensitizers. Add a prandial insulin also, that is bolus insulin. Bolus prandial insulin. That means you can give basal plus, that is basal insulin plus one bolus, either at morning, noon, night, or basal 2 plus 2 times. Basal plus 3 is a basal bolus. Okay, so begin prandial insulin before target meal. If not at goal, progress to injection before 2 or 3 meals. Start 10 percentage of basal dose or use just 5 units. Begin prandial insulin before each meal. So how to start the prandial bolus insulin we will discuss now. How to start a basal insulin, that is bolus insulin. Okay, bolus. See, suppose the patient is on 30 units of basal insulin. We were calculating it as 30 units. Suppose we know that it's a 0.2 to 0.3 units per kg per day. So still the blood sugar were not controlled. What we do? We have to use a basal bolus or you use premix insulin. These are the two regime when we reach a position where the using the basal insulin along with OHA, there is no control. The preferred method is basal bolus. We go for basal bolus. Okay, so starting a basal bolus regime. We told that 0.3 to 0.5 units per kg as total daily dose. For example, 60 kg man, it is taking the lower unit, it is 60 into 0.3, that is 18 units. Total daily dose of insulin is required. Okay, total insulin, including basal and including bolus. So in the 18 units, total insulin, that is 0.3 to 0.5, taking the lower unit. Among 80 units, 50% should be long acting, that is the basal form, and 50% should be bolus, that is the low short acting. That is 9 units basal, 9 units bolus. Among 9 units, you take 2/3 in the morning and 1/3, that is 3 units in the evening. So if patient is already on basal insulin, this is the starting basal insulin. You are starting this. This is a case. In case if your patient is already on basal insulin, this is a case where there is starting insulin, basal bolus. If I am taking a basal insulin of let's say 30 units, you just whatever amount is he is on basal insulin, we add plus one. That is adding basal bolus once a day with the major meal of the day. For Indians, the major meal will be lunch. You can initiate 10% of already taking basal insulin. For example, if you are taking 30 units basal insulin, you add 3 units. So you can add 10%, that is 3 units at noon. But practically, we start with 5 to 6 units regular at noon. Okay, next. What is the roller coaster mechanism of insulin? These are in case of the sliding scale, roller coaster mechanism. Suppose these are the sliding scale. If it is 150 to 200 used to units, 200 that, these and that, let it be like this. So if you are considering this roller coaster mechanism, 8 a.m. the RBS is 222. You administer according to this 222, that is 4 units. You administer 4 units. The insulin will act, and at 12 noon the RBS is 130. You see that it's 130, it's below 120, 150. No need to add insulin. But after that, you eat a good meal, chicken biryani or whatever it may be. It shoot up to 300 plus. See, 300 plus. So you give this 8 units biggest insulin you at 8. So 300 plus, and at 8 p.m. you see that the RBC is 300, 305 because you haven't given any insulin at noon. And you are seeing that it's 305. You add 8 units. It's a large quantity unit, you use 8 units. And it will go to 5 at the night. That is roller coaster, high and low roller coaster phenomena. So that is, we are not, should not use sliding scale as a master scale. Okay. So how much unit of sugar is reduced with 1 unit of insulin? Actually, when you talk about initiation of insulin, nobody can say how much sugar will drop with 1 unit of insulin. But if the patient is already on insulin, then we have a formula, 1800 divided by TDD, that is total daily dose of insulin. Total daily dose. So total daily dose of insulin, we told that the 50% bolus, 50% basal. So suppose a patient is of 60 units of basal bolus, total basal and bolus insulin. You take that is 30 units basal and 30 units bolus. You divide 1800 by 60, that is 30. Which means that in this patient, every 1 unit or each unit of insulin drops the blood sugar by 30 milligram per deciliter. Okay, by 30 milligram per deciliter. The egg why we have to say. Let's say the target sugar is 140, but the RBS is 200. What is the difference? The target sugar is 140, the difference is 60. So in such patient, each unit will reduce the sugar by 30. So how much units you need? You need 2 units to reduce 60 milligram to 60 milligram sugar. So these 2 units of insulin extra will cover 60 milligram. So it is a case of patient whose total bolus insulin is 60. Okay, scenario. Let's check a scenario. A patient is taking Lantus. Lantus is a long-acting insulin, glargine, 20 units, and Atrapid 1064. Atrapid is a short-acting insulin. So total of you taking 40 units of insulin. Suppose the blood sugar is 150 at the morning and 222 at the pre-lunch. Okay, so sugar value is 151 at 8 a.m. and 12 p.m. it is 2222 milligram. At pre-lunch, he was usually taking 6 units of insulin. See, 6 units he was taking. But that is not sufficient. Is that sufficient or not? Why? Because in morning it was 151, you taken 10 units. If at noon it become 2222, 10 units itself will not be sufficient. Okay, so 6 units will not be properly will not be sufficient. So what you do, you divide 1800 by 40, that will be 45 milligram. So each units of insulin will reduce by 45 milligram. So we need a target of around 140, right? So what we do, each unit will reduce it by 45 milligram. So if you use 2 units, 2 into 45, it will reduce by 90. It is 2 divided minus 90. It is 2, 12, 3. You have to use 2 units. Okay. So important thing you remember here it is 1800 divided by TDD, total daily dose, and each gram will reduce sugar of that. Okay. Previously we discussed the total basal insulin, basal bolus. How you start? You use this 0.3 to 0.5 units per kg per day, and you divide it in 50-50. Next comes how many times to monitor blood sugar. Very important. Depending on the type of OHA or insulin patient taking, ideally it's 7 times a day for basal bolus regime, but that's not practical. For that, we use a minimum 4 times a day. You would need a pre-meal, that is before lunch, before breakfast, before dinner, and after dinner. The reason for 4 times blood sugar estimation, what is the reason for 4 times sugar estimation is with breakfast, you know how to adjust the basal dose. That is fasting blood sugar depends on, we told that fasting blood sugar depends on the basal dose. And that is fasting blood sugar monitoring can adjust night basal dose. Also, depending on what fasting, you will decide how much bolus also you need. If it is 150 to 200 above, you can increase the bolus dose. That's simple. Before lunch value, tell whether breakfast bolus insulin you gave was okay or not. Let's say breakfast blood sugar was 130. If morning prandial dose is not sufficient, pre-lunch sugar will be high. Why do you need after dinner sugar value? After dinner sugar should not be less than 120, because if the sugar is below 120 at 2 a.m., it definitely the patient will go for hypoglycemia. Okay. You remember pre and post value should not be more than 50 milligram. So for the pre sugar is 130, the post prandial should be 150, not 180. Okay, it should not be more than that. If it is more than 190, suppose, okay, more than 990, it is definitely hyperglycemia. You should treat. So the key thing you remember is basal bolus calculation. The total daily loss is 0.5 to 0.3 to 0.5 units per kg per day. That is TDD. You can convert 50 percentage into bolus and 50 percentage into basal and bolus. And how much dose increasing, you take 100 and 1800 divided by TDD, and you get a value. That X value will be reduced for each unit of insulin. So thank you for listening. Have a nice day.